All right, hi there, welcome back. This is part two of the Drugs for Thromboembolic Disorders lecture. So let's move on to our next class of anticoagulants, and that is the vitamin K antagonist. Our prototype is warfarin. So warfarin is a very important drug. It is actually the only vitamin K antagonist in the United States. It's one of the oldest anticoagulants. It's been in use for decades. Even with some of the newer anticoagulants that have come to market in the last 5 or so years, warfarin is still pretty commonly used. So I know all of you will see this. This is definitely a drug you need to pay close attention to. This drug works by inhibiting vitamin K epoxide reductase. Essentially, that's an enzyme that is necessary to convert vitamin K to the active form. And activated vitamin K is necessary for the production of vitamin K dependent clotting factors. So factors 2, 7, 9, and 10, these are all vitamin K dependent clotting factors. So warfarin will decrease the activity of those factors by anywhere from 30 to 50%, and that's how it exerts its anticoagulant effect. So a couple things to know about warfarin. First of all, its effect is delayed. And there's a couple reasons for this. So the actual onset of anticoagulant effect is usually not seen until 2 days. In some patients, it's even longer, maybe up to a week. And this has to do with the fact that warfarin is only affecting the production of new factors. All of those activated clotting factors, all of those vitamin K dependent clotting factors that are already floating around, those, warfarin has no effect on those. So the body has to use those up. Essentially, it's kind of like the concept of half-life. So those clotting factors have a half-life, and it's going to depend on 4 to 5 half-lives before we see those clotting factors out of the system and no longer really contributing to coagulation. So the one that we worry most about is factor 2. Factor 2 is very important. It has a 60-hour half-life. So that's definitely going to contribute to that slow onset of anticoagulant effect. The other thing is the long half-life of warfarin. So warfarin itself has a long half-life. So those two factors really play into this idea of a slow onset of anticoagulant effect. The other kind of key point with this is early on in the first day or 2 days or even 3 days after a patient has been started on warfarin, they could potentially be in a hypercoagulable state, which seems counterintuitive. But it again has to do with the fact that those factors, those vitamin K factors that have already been synthesized are still floating around in the bloodstream, potentially causing coagulation. But the other side of the coin is that the body also has naturally occurring anticoagulants. So I mentioned these in the patho review, protein C and protein S. These are naturally occurring anticoagulants. They are also vitamin K dependent, and they have very short half-lives. So the actual circulating protein C, especially protein C, but also protein S, these concentrations dwindle very fast. And so that kind of leads to that potential hypercoagulable state. And this is why when we use warfarin for treatment of DVT or PE, in many cases the patient will be on heparin and then we'll do what we call bridging. So they'll be on heparin for several days while we're waiting for the anticoagulant effect of warfarin to kick in. So generally, usually it's somewhere in the neighborhood of 4 to 5 days, but it can vary based on the patient. But it'll always make sure that we have a therapeutic INR for at least 24 hours, along with at least 2 days of heparin therapy concomitant with warfarin. So that's called bridging. You may hear of that. You certainly will see that in practice. So that's for those patients that have an active clot. Some patients, though, we're just starting warfarin. They don't actually have a clot, but we're using it as prophylaxis. So, for example, some patients with AFib, warfarin will just be started on its own without heparin along with it. But like I said, those acute situations where the patient has an actual clot, that would be a different story. It's also used for prophylaxis of clotting due to prosthetic heart valves. This drug is only available orally. So it is, different clearly from heparin and those other agents that are parenteral. This drug is only available by the oral route.
Adverse effects, again, the most concerning, bleeding. Luckily, we do have a reversal agent, and that's vitamin K. Vitamin K, also known as phytonadione, this will compete more successfully with warfarin, and it allows the liver to actually synthesize factors that can be effective. Some patients will prefer to give either whole blood or fresh frozen plasma. And that's usually when the patient needs to remain on anticoagulation. So say they just need to go to a short procedure, but they need to remain anticoagulated. So you'll just give them blood or FFP kind of in that interim period. And then when that wears off, they'll still be on warfarin. But sometimes you want to actually reverse them and completely get them off anticoagulation. In that case, they'll be given vitamin K. A couple of very important things to know about warfarin. Teratogenic. This drug is Category X. Category X means the drug should never be given to pregnant patients. Patients who are on this drug should be educated that if they become pregnant, it can cause very serious adverse effects for the fetus. It can cause fetal hemorrhage, can cause gross malformations, CNS defects, optic atrophy. If the patient delivers the pregnancy and then is breastfeeding, this drug enters the breast milk, so it can also put the baby at risk for bleeding as well if they're nursing while the mom is on this medication. Another adverse effect is skin necrosis. This is pretty rare. I don't think you guys need to worry about that. The two that are the most important, bleeding and teratogenesis, you absolutely have to know.
And here's just an example of a patient who did experience warfarin-induced skin necrosis. This is one of the least ugly pictures that I've seen of this. When it does occur, it can be pretty nasty. Obviously, even in this picture, it's not a good situation. But it can look even worse than what you see here.
Some sources of individual variation. Pre-existing bleeding disorders. So patients who have, for example, hemophilia, they would be at increased risk of bleeding if they're also given warfarin. Active peptic ulcers or ulcerative colitis, head trauma, some of the similar situations that we talked about with some of our other anticoagulants. This drug is metabolized by the liver, so patients with extensive liver disease or alcoholism will definitely need lower doses. Patients who aren't compliant, this is not a good drug for patients who aren't compliant. And that's because the drug needs to be monitored very closely. The drug has a very narrow therapeutic index. And so if these patients aren't compliant and they're just kind of sporadically taking their medication, number one, it's not going to be effective. Number two, if they try to, double up their dose or something like that because they know they haven't taken it for a few days, that can actually put them at risk for bleeding. So compliance is a very important factor in deciding whether or not somebody should get warfarin. And then malnourished patients. Diet can have a big impact on this medication because of its impact on vitamin K. And so patients who are malnourished, it can be difficult to manage them on warfarin. Finally, never use this in a pregnant patient. I already talked about the fact that this drug can cause very serious forms of teratogenesis. Drug-drug interactions. You absolutely must know this. You have to know that there are many, 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 many drug interactions with warfarin. Always check before you administer this medication. always check to make sure that the other medications your patient's on will not interact with warfarin, or if they do interact with warfarin, that they've been adjusted appropriately to account for that drug interaction. Some that I want you to know, I have listed on the slide Bactrim, which is sulfamethoxazole trimethoprim. We'll talk about that drug next week. SMX TMP is kind of the shorthand version for that drug, but that drug is just Bactrim. You have to know that Bactrim and warfarin interact. Metronidazole or Flagyl is another antibiotic. We'll talk about it in a week. Absolutely vital that you know that those two drugs interact. Amiodarone, fluconazole, steroids, rifampin, phenytoin, all of these drugs are very important to know. These are potent inducers and inhibitors, so you already know these drugs. You already know that they cause drug-drug interactions, but definitely know that these drugs interact with warfarin. Drug-food interactions. This is also extremely important to know. Vitamin K-rich diets can antagonize the effects of warfarin. So if the patient eats a lot of liver or broccoli or Brussels sprouts, kind of like your green leafy vegetables, it can be very difficult to get these patients into therapeutic range. So, what we usually tell patients is be very consistent with your diet. So it's not like you can, we're saying you can never ever have broccoli again. What we're saying is if you eat broccoli, be sure to eat it about once a week. If you eat liver, make sure you're, keeping your servings consistent. You don't want to never eat liver and then all of a sudden eat liver 5 days in a row. Because if you do, the patient's INR is going to drop and they're going to be at risk for thrombosis. Or vice versa. If they eat liver all the time and then they stop eating liver altogether, they're at risk for their INR going up and potentially causing serious life-threatening bleeding. So consistency is key when it comes to diet. So kind of like unfractionated heparin, warfarin is started at a standard dose and then the dose is adjusted based on based on monitoring the anticoagulant effects of warfarin. The test that we use to monitor warfarin is the prothrombin time, or PT. Now, kind of like heparin, where I talked about, different hospitals would have different ranges, the same previously was true for the PT. But luckily, nowadays we don't just look at the PT, we look at what's known as the PT INR. And the INR is a way to ensure that test results from different labs are comparable. So the PT will be reported in terms of the INR, which stands for International Normalized Ratio. So I'm not going to get into exactly how the INR is determined, but the bottom line is we can look at the INR, and from that INR we can determine whether or not the patient's warfarin dose needs to be increased or decreased, or whether it can remain the same. The typical INR range, the usual goal range for the majority of patients, is 2 to 3. Now, there are some patients where we would target a slightly higher goal. For example, 2.5 to 3.5. That would typically be the case for patients with mechanical valves, but it's not always the case. So I think for our purposes, you can just know that the usual range is 2 to 3. When you're taking care of a patient, what you need to look up is, what does the provider say the goal range is for that particular patient? And does that goal range make sense based on what you know about the patient? And then how you'll utilize this is, prior to administering warfarin, you'll look up the goal range, and depending where the patient is in therapy. So if they've just started therapy the day before, you would not expect the INR to be in goal range, right? We talked about the fact that it takes several days for the INR to become therapeutic. Sometimes it takes 6 or 7 days. Generally, it takes somewhere in the neighborhood of 4, maybe 5, maybe as many as 7 days. So once the patient is in the goal range, the INR will be monitored less frequently. So in those initial few days, it could be monitored every day. If the patient's in the inpatient setting, it's probably going to get monitored every day. If the patient's in the community setting, they'll probably come back to the clinic every other day or something like that. Once the patient is in goal range, then generally they'll be monitored a couple times a week. Once they've been stable for a week or so, then they'll go to monitoring every 2 weeks. Once they've been stable every 2 weeks, then they could go to every 3 weeks. And generally, the longest interval that we would see is usually every month, unless the patient is a highly compliant patient or highly adherent patient, highly reliable patient, with a able to monitor, kind of self-monitor therapy. Usually patients are seen pretty much on a monthly basis to reassess the INR. And again, depending on what that goal range is, their dose may need to be decreased or increased. So the bottom line with warfarin is that there is a dose, that kind of a standard dose that we would start with, that would be based on the patient-specific variables. But then from there, the dose is completely monitored and adjusted based on the INR results. So patients who are on warfarin have to have the ability to go to clinic and have their blood drawn and have those INR results reviewed. Other labs that we might monitor, obviously the CBC. So up front, the patients, we would get a CBC, and then ongoing we would look at CBC. Largely that's because we're looking at hemoglobin and hematocrit, potentially platelets. All of that is kind of the complete picture with regards to the patient's hemostatic condition. And then, of course, ongoing, we would be looking for signs and symptoms of bleeding or thrombosis. I like this diagram a lot. I think this, for me at least, this always helped me to remember what my goal INR was. And so what you see on this slide is kind of risk on the vertical axis and then your INR on the horizontal axis. And you can see what this slide is showing you is that there is a risk trade-off with your target INR. So kind of in that middle zone, you've got your thromboembolic events coming down, and you can see your hemorrhagic events going up. That's why you want that sweet spot of 2 to 3, because you're minimizing your risk of thromboembolic events and you're minimizing your risk of hemorrhagic events. All right, so some important nursing implications with with warfarin. First of all, warfarin is available as both a brand and generic. And the reason I mention that is a lot of drugs are available both brand and generic, but this drug has a narrow therapeutic index. This drug has a lot of interpatient variability because of its pharmacokinetics. And so even though warfarin and Coumadin are considered bioequivalent, it's probably not a good idea for patients to kind of switch in between these, 1 month getting warfarin, next month getting Coumadin. Really, you want the patient to stay on whatever generic they're on kind of indefinitely. If for some reason they need to switch to the brand, that's okay, but they're going to need close monitoring in that time frame, usually for about a month after they've switched. Another important point, thorough med history. So when you're taking a med history, making sure you're asking really good questions about what drugs are these patients on, when did they have their last dose, how consistently are they taking their warfarin, are they taking any complementary medications, because complementary medications can also be involved with drug interactions with warfarin. So those are just some of the important points in your med history. Reviewing and evaluating the INR before administering warfarin, very important. This wasn't always the nurse's responsibility, but I would say in the last 5 to 10 years, this has become a standard part of nursing care. And it's not just the nurse. Everybody involved in care is responsible for making sure they know the INR, they know the goal, and they're evaluating that in response to therapy. So the prescriber, the pharmacist, the nurse, and anybody else that's caring for that patient where the INR could be of importance. And then education. So high impact education. There's a lot that goes into education for patients on warfarin. Making sure they know that warfarin and Coumadin are the same thing. Making sure they understand the signs and symptoms of bleeding and thrombosis. You guys should know the signs and symptoms of bleeding and thrombosis. For example, signs and symptoms of bleeding such as discolored urine or stool, bruises, persistent headache or fainting, excessive gum bleeding, things like that. So you want to make sure that they understand those signs and symptoms and how to manage those signs and symptoms. Monitoring. So make sure they understand that this drug must be monitored. There's no standard dose for this drug. This drug is monitored based on blood tests. And so explaining to them that they're going to have their INR monitored regularly. Most likely they'll be going to some kind of Coumadin clinic or warfarin clinic where it's somebody's job to specifically monitor their warfarin and adjust it appropriately. Make sure they understand their dose schedule. In many cases, they're kind of convoluted dosing schedules. If you can give them a chart, that can usually be helpful. Make sure they understand the impact of diet. So they need to be provided with a list of foods that are high in vitamin K content, and they need to understand if they're going to eat those foods, they need to be very consistent with eating those foods. They can't just kind of eat them on a whim because it's going to impact their INR if they do. Make sure they understand that drug-drug interactions are prevalent with this medication. It interacts with almost everything. And so they've got to tell everyone, I am on warfarin. I understand that this could be involved in drug-drug interactions. So anytime new drugs are prescribed, there needs to be a discussion of whether or not it's appropriate for that drug to be given while the patient's on warfarin. Maybe it is. Maybe they just need to reduce their dose of one of the drugs. But there definitely needs to always be that discussion. I wanted to point this out to you guys. I think this is a nice thing that the FDA did many years ago. They've standardized the color of the warfarin tablet. So regardless of who makes that drug, I don't know, there are probably 3 or 4 different generic companies that make warfarin, plus the branded Coumadin that company that still makes warfarin, and all of them use the same color scheme. So the reason why this can be helpful is if the patient is on 1 milligram and they've been on that for a while, and for some reason they open the bottle that they got from the pharmacy and now the medication is green, that's something that they can look out for and say, hey, wait a minute, I think there's an error here. And so definitely educate them about the color of the tablets and the fact that that should be a consistent thing for them, unless their dose or their strength has been changed. All right, so Miss Bleeden. So she's been on that heparin infusion for 3 days, and the medical team is discussing when to start warfarin. Some current lab data for her serum creatinine is 1.4. Her most recent APTT, which was with the AM labs, that's what AML stands for, was 75. So first and foremost, her APTT is in the normal range. Remember, she was on the standard nomogram. So her goal was 50 to 80. Her goal APTT was 50 to 80. So question, when can warfarin be started now? So think about that question. And I also want you guys to think about what other information might you need. So if you say, yes, warfarin can be started, or no, warfarin can't be started, what other information do you need to think through this case? So pause the tape. You might want to take a look back at some of those warfarin slides, and maybe even go back to Ms. Bleeden, back when we were talking about her, when we reviewed heparin as well. Pause the tape, think through these questions, jot down some notes, and then restart the tape, and I'll walk through kind of some of the key points. Okay, so hopefully you took some time to really think through this case. First and foremost, I would say yes, warfarin can be started at this point. So some things to think about with this. And this is prescriptive, so it's not that you'll necessarily need to be the one making this decision, but it would be good for you as the nurse to understand when it's appropriate for the warfarin to be restarted. So you can advocate for your patient if need be. So she had an active PE. When we talked about heparin and when I was talking about warfarin, I said that warfarin, when you first initiate it, can be thrombogenic, right? So it can increase the risk of clotting because it takes several days to work. Because she has an active clot going on, we would want her to be fully anticoagulated before we start her warfarin. So she's been on heparin for 3 days. We know that her current APTT is within range.
So it would make sense to look back over the last 24 hours and make sure that she's been in range for at least the last 24 hours. But, I would say, given her history, we can say yes, she's been, her current APT is in range, and we look back and she's actually been in range, in goal range for the last 2 days. So at this point, it would be reasonable to start warfarin. So other questions at this point that we would need to think through if warfarin is being started. So just like with the other anticoagulants that we talked about, there are some contraindications that we have to consider. Now, we've already considered the contraindications related to bleeding. We considered those when the heparin was started. But was there anything specific to warfarin that we hadn't previously evaluated? So hopefully you looked back and you recognize pregnancy status. Now, our patient, Ms. Bleeden, probably is not pregnant given her age, but we would, still want to verify that. Liver disease. So does this patient have liver disease? Does she have a history of alcoholism? These are things that we would want to look into. We might even need to look at labs, especially related to the liver. If we find that she does have a history of liver disease, we would want to look at her liver function tests and other tests that are indicative of how well her liver is functioning. We would also want to look at her nutritional status, right? Because patients that are malnourished might respond differently to warfarin than patients that have a normal nutritional status. So any labs that we might need to look at regarding her warfarin, especially, as I said, those related to liver function. The other thing I would hope you guys identified is that warfarin has a lot of drug-drug interactions. So we would need to look at her medications and see were there any medications that could be a potential problem with regards to drug-drug interactions. It's beyond our class and what we're talking about, but if you're interested, there is a policy at Hopkins for warfarin management, just like heparin, just like the heparin policy that we talked about. Explains how to start a patient on warfarin. So kind of all the variables that you would consider when patients are being started on warfarin, very much beyond the scope of this class, so it's not required that you take a look at it. But if you're interested, you can certainly go and take a look at it. Some of the things that are considered is, when would you start a patient on a lower dose of warfarin relative to maybe a standard dose? For example, elderly patients, especially patients older than 75, tend to be more sensitive to warfarin, so we start them at lower doses than a standard patient. Our Ms. Bleeden, though, she's pretty standard patient in terms of her history, her age, her weight. So she's going to be started at 5 milligrams daily, which is a pretty standard dose. That's probably the most typical starting dose for warfarin that you'll see. It's a couple days later, so at this point she's received 3 doses, and her INR is as follows. So on day 1, her baseline INR was 1. On day 2, her INR inched up a little bit to 1.2. Today is day 3, and her INR is 1.4. So I would say she's kind of coming up nicely. If I had to guess, her INR probably would be maybe 1.7 or 1.8 tomorrow. Maybe on day 5 it would even be up as maybe even into the therapeutic range at 2. So what is her INR goal? That's my main question for all of you. It's day 3. Her INR is 1.4. You're going to administer her dose, but you need to look at her INR goal and you need to look at her current INR before administering that goal. So what is her INR goal? Secondly, I want you to think about whether or not her heparin infusion could be stopped at this point. And so think about some of the discussion that we had around warfarin and when it's acceptable to discontinue heparin, or when you might expect the team to discontinue heparin. So again, pause the tape, think about these questions for a few minutes, and then restart the tape, and I'll talk through some of the responses you may have come up with. Okay, so hopefully you thought about those. It's perfectly fine to go back and look at some of the past slides to help you answer these questions. So her INR goal, she is a typical patient. I said the typical INR goal is 2 to 3. If she had a fib and she had a valve replacement with a mechanical valve, her goal might be a little higher, 2.5 to 3.5.
But her goal is the typical goal, which is 2 to 3. So she's not quite in the therapeutic range yet. And so because of that, we would not stop her heparin infusion yet. Remember I said for patients who have active venous thromboembolism, we want them in the therapeutic range before we stop the heparin infusion. So we want their INR, their warfarin, the warfarin INR to be in the therapeutic range. Generally, there's an overlap for the heparin, GERP, and the warfarin for 5 days, and you want the INR to be in range for at least 24 hours. So basically, that means you have 2 INRs that are in range. So she's not quite at that point yet, so we would continue her heparin for at least a few more days, at least 2 more days, right? Because we say 5 days and an INR that's in range for at least 24 hours. So she's looking at least 2 more days, probably even maybe 3 more days. All right, so one last question for her. She's been on warfarin for several days. She's been on argatroban. The warfarin is beginning is therapeutic at this point. She is going to be discharged in the coming days. And so you need to provide her with patient education. So I want you to think about some of the education points that you would include once she's able to be discharged. So why don't you go ahead and write out some of your ideas. I'm not going to actually go through this because I just talked about this a few minutes back, but pause the tape and write down some of your ideas and go back to our nursing implications slide for warfarin and see if you were able to come up with all of the important points. So moving on, our next class of anticoagulants are the direct thrombin inhibitors, and our prototype is dabigatran. Dabigatran and other direct thrombin inhibitors are considered anticoagulants. They work by direct inhibition of thrombin. So they are a little different from the heparin-like anticoagulants. The heparin-like anticoagulants also inhibit thrombin, but they do so indirectly. They do it by enhancing the activity of antithrombin. These drugs are direct thrombin inhibitors. They're going to directly inhibit that factor 2A. There are 4 of these drugs on the market. Dabigatran or Pradaxa is the only one that's given orally. It is our prototype, so that's the one I want you to be familiar with. There's also a drug that can be given sub-Q, and there are 2 that can be given intravenously. So one of those intravenous drugs I'm going to ask you to know, and I will tell you the context under which you need to know that. Before I do that, let's talk about the therapeutic use. This drug is currently approved for prevention of stroke or systemic embolism for AFib patients only. In Canada, it's also approved for prevention of VTE following knee or hip replacement. I imagine that eventually it will be approved for that use as well in the United States and probably other uses. It's being studied as we speak for a variety of different uses, but currently it just has one approved use. Adverse effects, by far the most concerning adverse effect is bleeding. Very similar to the other anticoagulants we've already talked about. So bleeding is the major concern. This drug can also cause some GI disturbance, such as dyspepsia or gastritis. And so for those patients, if they do experience these symptoms, it can be reduced by taking the medication with food, or by using an acid suppressing drug like a proton pump inhibitor or an H2 blocker. If this doesn't help, then these patients would need to be switched to warfarin, which has a lower risk of GI problems. But hopefully the patients don't experience that severe GI disturbance. There are some drug-drug interactions to make note of. Ketoconazole, amiodarone, verapamil. These drugs all inhibit P-glycoprotein transporters, and so they can have an impact on this drug's metabolism. And so those 3 drugs, I think you should know them. You could be asked on your boards about this. Additionally, any drug that impairs hemostasis. So if obviously, if you've got other drugs that impact hemostasis and they're being used concurrent with this drug, that could increase the risk for bleeding. Individual variation, this drug is cleared renally. So for patients with renal dysfunction, um, their dose may need to be adjusted. And as I mentioned, dabigatran is given orally. The other drug that I want you to know is argatroban. All I want you to know is that argatroban is a direct thrombin inhibitor. It's intravenous only, so it's given by a continuous intravenous infusion. And this is the drug that's used for patients who experience HIT from heparin. So if you have a patient on heparin, they develop HIT, they're going to need anticoagulation once the heparin's discontinued, and almost always the drug they're going to get is argatroban. So the reversal agent, there is a reversal agent available. It's actually only been on the market for a short period of time. It's called idarucizumab. That's a hard one to pronounce. Brand name Praxbind. And the reason why it's called Praxbind is because of the way it works. It actually binds up the drug so that it can't inactivate thrombin. Nursing implications, as I mentioned already, you can take this drug with food or administer this drug with food to decrease dyspepsia if your patient is experiencing those side effects. And then, of course, very strong education for this drug. High impact education, just like with your anticoagulants, making sure that the patient is familiar with the signs and symptoms of bleeding, thrombosis, also making them aware of the potential for serious drug-drug interactions. Also, this drug is in a capsule form, and if the patient opens up the capsule and pours the contents over food, it increases the bioavailability of the drug by 75%. So think about that for a moment. If you increase the bioavailability of the drug by 75%, that means that you effectively are increasing the effects of that drug by 75%. That can be a life-threatening situation. That could lead to life-threatening bleeding in these patients. So these patients must be educated not to open the capsules. Now, you might think, well, oh, they just won't do that. That wouldn't occur to them to do that. The problem is there are other capsules that we can open and pour over food to make it easier to swallow. And so if they're on another medicine where they're able to open the capsules, they might think that it's okay to do for this drug, but you have to educate them that it is not acceptable. And then my last point is tell everyone. I made this point when we were talking about heparin and low molecular weight heparin, and the fact that if you're on these medications, you have to let people know that you're on them because there could be other drug-drug interactions. These patients are at a higher risk for bleeding, and so other healthcare professionals need to have that information.
So dabigatran or Pradaxa is currently only available as a trade product. You can see the product does have a warning, swallow capsule whole, but what's dispensed in the inpatient setting to the nursing unit, most likely you won't see this packaging. And it's possible that the patient may not be dispensed the product in this packaging either. So being sure to always let patients know that they can't open the capsule. It's got to be swallowed whole. Otherwise, they could experience serious bleeding.
All right, so let's move on. So our final anticoagulant that we're going to talk about is rivaroxaban, which is a direct factor Xa inhibitor. Rivaroxaban, or the brand name Xarelto, is a direct factor Xa inhibitor. It selectively inhibits factor Xa, and this inhibits the production of thrombin. It is used for VTE prophylaxis in patients undergoing knee and hip replacement. Sorry, I keep making that mistake. So they've gone through these knee or hip replacement surgeries, and they're at high risk for DVT. And so those patients get VTE prophylaxis, so this drug is appropriate for that. Can also be used for the treatment of DVT or PE, and it is approved for prevention of stroke in AFib patients. One important point, I would say that the most common use for this drug is prevention of stroke in AFib patients, but I do want you guys to recognize that the dosing varies based on indication. So the dose for VTE treatment is going to be higher than the dose for prevention of stroke in AFib patients. Drug-drug interactions. So you've got to know this. Now, I'm not asking you to know all the different drugs that can cause interactions, but what I want you to know is that rivaroxaban is a 3A4 substrate. And because it's a substrate, any drugs that are potent inducers or potent inhibitors can influence this drug's metabolism. And because of that, the patient could be at risk for thrombosis in the case of if they're given a potent inducer, or they can be at risk for serious bleeding if they're given with a potent inhibitor. So definitely be familiar with that. Now, this drug is actually rivaling warfarin. This drug, you've probably heard about this drug advertised. I see advertisements for this drug all the time. It does actually have some nice advantages to warfarin. Number one, it works pretty quickly. So it's got a pretty rapid onset because of its pharmacokinetics. It's got a fixed dose. So we don't titrate the dose based on levels or anything like that like we do for warfarin. It does have a lower bleeding risk. So in trials, it's been shown to have a lower bleeding risk. It's got few drug-drug interactions in relation to warfarin. Now, with that said, you do still worry about potent inducers or inhibitors with this drug, but warfarin interacts with just about everything. So while there are drug interactions with this drug, there are fewer than there are with warfarin. And like I said, it's got a fixed dose, so there's no INR monitoring. And so because of that, this drug is starting to become pretty popular. It's given orally. Just like the rest of the anticoagulants, bleeding is our major concern. Currently, there is no specific antidote available for this drug. However, there are several drugs under development that probably will be coming out in the next couple years, I would guess. So ultimately, there will be a reversal agent for this drug. Spinal hematoma is another concern. So if a patient's on this medication and they're going to have spinal puncture or epidural analgesia, this drug should be discontinued at least 18 hours prior to catheter removal, plus 6 hours after it's removed. So the drug shouldn't be, the anticoagulant drug, this drug should not be restarted until after the catheter has been out for at least 6 hours. In the case of a traumatic puncture, waiting at least 24 hours before starting the medication is prudent. Individual variation, so this drug can cause, this drug's clearance can be reduced for patients with hepatic impairment and severe renal impairment. And also it should be avoided in pregnant patients. Some nursing implications, so signs and symptoms of bleeding or thrombosis. Just like every single anticoagulant we've talked about, you should be educating your patients on signs and symptoms of bleeding or thrombosis. You should let the patient know that this drug can be involved in some serious drug-drug interactions. And then, of course, tell everyone. So that's like the little motto. Any patient who's on an anticoagulant should be telling all of their healthcare professionals that they're interacting with that they're on an anticoagulant, because that could change the course of therapy for something else the patient is being treated for.